Is exercise effective for neck pain? In 2008, it was reported that 50% to 75% of individuals with neck pain still had pain 1 to 5 years later. It would seem then that standard approaches may not be as effective as once hoped. Clearly, it's imperative to find appropriate effective management strategies. So, turning to the literature, what do we know about exercise and neck pain? It seems so obvious that exercise is a good thing, so why would we need to know if there is evidence regarding its effectiveness? Well, as usual, it's important to challenge our assumptions and look to see if exercise has been studied and whether it's been shown to have value for neck pain, and does it have added value when used with other care. I think you might be surprised by what the literature to date says. Back in 2010, a task force on neck pain and whiplash-related disorders from the Bone and Joint Decade published a review on diagnostic and management approaches for neck pain. The current review we will summarize is an update of the literature since that publication. It's entitled, Is Exercise Effective for the Management of Neck Pain and Associated Disorders or Whiplash-Associated Disorders? A systematic review by the Ontario Protocol for Traffic Injury Management Collaboration, published in the Spine Journal in 2014. To summarize, the purpose of this review was, quote, to update the work of the Neck Pain Task Force on the effectiveness of exercise compared with other interventions, placebo sham interventions, or no intervention for the management of adults or children with grades 1, 2, and 3 neck pain or whiplash-associated disorders, unquote. So what is this classification? It's the Quebec Task Force classification of grades of whiplash-associated disorders. There are 4 grades. 1. Subjects with neck pain and associated symptoms in the absence of objective physical signs. 2. Subjects with neck pain and associated symptoms in the presence of objective physical signs and without evidence of neurologic involvement. 3. Subjects with neck pain and associated symptoms with evidence of neurologic involvement, including decreased or absent reflexes, decreased or limited sensation, or muscular weakness. And 4. Subjects with neck pain and associated symptoms with evidence of fracture or dislocation. Let's look first at the major studies and conclusions that were included in the 2010 Task Force document. In this RCT by Brantford et al., the results indicated that exercise for neck pain with or without spinal manipulative therapy could provide more long-term improvements in disability than spinal manipulative therapy alone. In another study by Chu et al., the results indicated that both exercise, activation of deep neck flexors, and progressive dynamic flexion extension resistance training, and transcutaneous electrical nerve stimulation led to similar outcomes in patients with persistent neck pain. Both interventions resulted in greater reductions in neck pain and disability compared with infrared therapy. There were several studies from the workforce literature. One demonstrated that strengthening and endurance exercises for the neck flexors and upper extremities, either alone or when added to a multimodal physical therapy program, yield similar outcomes for pain and disability. In another study, exercises for the neck and shoulder produced similar long-term clinical outcomes as group-based relaxation training or advice to continue usual activities. For exercise and whiplash-associated disorders, the task force found only one RCT that demonstrated that home-based range-of-motion exercises resulted in greater pain reduction and diminished need for sick leave compared with written information and advice for recent whiplash patients. Now to this review, some important features related to the criteria used for study qualification and inclusion. For comparisons, the researchers included studies that compared exercise with other modes of non-surgical care, a wait list, or no intervention. And the requirement for outcomes was that the studies had to include one of the following: self-rated recovery, functional recovery, pain intensity, health-related quality of life, psychological outcomes such as depression or fear, or adverse events. Also, they reviewed studies that had not been reviewed by the Neck Pain Task Force, which included randomized controlled trials, cohort studies, or case control studies. There was an additional requirement that there was a minimum of 30 participants for RCTs and 100 participants in cohort or case-controlled studies. There were 2 phases of the review. In Phase 1, random pairs of independent reviewers screened citation titles. In Phase 2, the same pairs of reviewers independently screened possibly relevant studies to determine eligibility. Reviewers met to resolve disagreements and reach consensus on the eligibility of studies. A third reviewer was utilized if consensus could not be reached. Let's look at how many articles were found and how many qualified. This will illustrate the limited number of quality studies out there. There was a total of 4,761 articles that met the search approach, but there were 1,035 duplicates, and 3,705 did not meet the inclusion criteria. This left 21 articles for critical appraisal. Only 11 were admissible. One was an analysis of another study, which left only 10 studies. Again, to demonstrate how hard it is to combine studies for comparison and make statements regarding effectiveness, specifically there were 7 different types of exercises included. 8 out of 10 RCTs combined exercises into one program. 7 RCTs evaluated supervised programs, while 5 RCTs evaluated unsupervised or home programs. 9 out of 10 programs were conducted in clinics and 1 in the workplace. And variations of frequency or care included anywhere from 3 times a week to daily, and 1 to 2 times per week for supervised exercise. And duration ranged from 6 weeks to 12 months. Co-interventions were not adequately described or accounted for in 8 trials, and 5 RCTs reported high attrition or different attrition rates among treatment groups. Now let's look at the findings regarding recent grade 1 and 2 neck pain. For home exercise, 1 RCT suggests that a home exercise program, nonsteroidal anti-inflammatory drugs and acetaminophen, or multimodal manual therapy lead to similar outcomes for patients with recent grade 1 and 2 neck pain. There were differences. However, these differences did not reach clinical significance, and there were no clinically significant differences in pain or disability between groups, the home exercise group and the manual therapy group, and at all follow-up intervals. One study found that 18 group sessions over a 6-month period of supervised Qigong were associated with greater improvements in neck pain compared with a weightless group in the short term. The differences in pain reduction among groups were clinically important after the 6-month intervention. So what is Qigong? This is a meditative movement approach developed and utilized in China for centuries. The intention of the exercises is to facilitate energy flow in the body's meridians through controlled breathing exercises. In a similar study, there were no clinically significant differences among patients in the Qigong group and those randomized to 18 supervised exercise sessions combining cervical range of motion, strengthening, and flexibility exercises. In other words, either seemed equally effective. Another RCT found that 24 group sessions of supervised Qigong over a 3-month period were associated with clinically important reductions in neck pain compared with a weightless group after the 6-month intervention period. Evidence from one RCT suggests that supervised yoga is more effective than education and home exercise for short-term improvement in neck pain and disability. After the intervention, the yoga group reported greater improvements in pain intensity, symptom bothersomeness, disability, health-related quality of life, and depression compared to the control group. Clinically important between-group differences at 1 week post-intervention included a visual analog scale at rest of 23.8 millimeters, a VAS at motion of 21.5 millimeters, short-form 36 health survey of 7.4, and depression of 10.2. And now moving to recent grade 3 neck pain and associated disorders. Remember, this includes neck pain with objective neurological findings. A supervised graded strengthening exercise program is more effective than advice but leads to similar outcomes as a semi-hard cervical collar with prescribed rest. There were no clinically significant differences in neck pain and disability between the exercise group and those randomized to wear a semi-hard cervical collar and rest. Interestingly, a higher proportion of participants in the exercise group, 45%, remained on a partial or complete sick leave after completing the 6-week intervention, compared to those treated with a collar, 29%, and those in the control group. Let's compare the Neck Pain Task Force findings with the current review. In the Neck Pain Task Force review, they concluded that exercise was more beneficial than manual therapy, TENS, neck collar, or simple advice for the management of persistent neck pain, but did not find evidence that strengthening exercises were more effective than endurance exercises. And in the current review, they found evidence that supervised exercise programs including Qigong, yoga, combined range of motion, strengthening, and flexibility exercises were more effective than advice or being on a wait list, in other words, natural history. They too did not find that strengthening exercises were more effective than endurance exercises. The most recent evidence from this review found that supervised strengthening exercises are equivalent to home exercises for the management of persistent neck pain. Qigong exercise programs were equally effective to programs combining strengthening, range of motion, and flexibility exercises, and there is no evidence of one type of program being superior over another. So, to further summarize, patients with recent neck pain grades 1 and 2 have similar outcomes whether they're managed with home exercise, multimodal manual therapy, or medication, and are more effective than a wait list or advice to stay active in patients with persistent neck pain. However, the risk of mild transient adverse events is higher for those who take NSAIDs or acetaminophen. And evidence from 3 RCTs indicates that supervised or unsupervised strengthening exercises alone are not more effective than home exercises, which included stretching or range of motion. And most studies reported small effect sizes, suggesting that a small clinical benefit can be expected with the use of exercise alone. Disappointing? Certainly for those who believe that success depends on the type of exercise, but it does overall suggest that for neck pain without neurological involvement, being active is more effective than rest or advice. And for those with neurological involvement, a semi-hard collar might beat out exercise. Finally, 2 approaches that are not necessarily part of everyone's management strategy might have some value, including yoga and Qigong.